happy Monday, happy May, happy Dimensions training. So my name is Martha Sawyer, and I've been an occupational therapist for 10 years, a majority of which I've worked with geriatrics, specializing in dementia care. And I've been with senior services, so through Fairview Home Care, for a year and a half. And part of what I've been doing in my year and a half with senior services is asking myself the question, how can I help? How can I help with this Dimensions program? I'm primarily out of Bloomington, so I work with Juanita at 9 Mile Creek. I'm also at Meadowwoods in Bloomington, and then I'm covering throughout the metro as well in other buildings, and I'm seeing the Dimensions programs. I'm seeing bits here and pieces here, and I just want to help in any way I could. So I met Juanita.
I'm Juanita Schuler. I have been with Ebenezer about 11 months now. Have been doing senior care for about 15, 16 years. Absolutely love dementia and Alzheimer's. So it's kind of my baby. So being able to implement the Dimensions program when I came on proved to be a bit of a challenge. And I am not afraid to ask help, so pulled Martha in, and that's how this all kind of started moving.
So over the last few months, Juanita and I have been working together to try to implement some care plans or some ideas at 9 Mile Creek. And so our plan today is to tell you our journey, introducing you to these care plans. I think they've been emailed out, you've gotten a chance to look at them, but really to give you hands-on case studies, how this works, how it came to be, and how to implement it. So we're going to introduce you to the care plans. They should be in your handouts or via email. They were sent out. We're going to talk about what we learned from their development, because it was like not a straight line. Nope, it's never a straight line. So we learned through our journey so that we don't have to recreate this at every site, the journey to get here. So we're hoping that we're going to present a kind of a new gold standard of how to implement Dimensions care planning. We're going to, through our last few months, we developed a standardized process that I'm using as the occupational therapist that serves 9 Mile. And so I have also trained the senior services occupational therapists on this process as well, that we hope to be rolling out to all the sites on how to communicate between the two teams. We have a couple case studies that we're going to talk about, how this has worked. And then I'll do a quick review on how to determine that global deterioration scale, and ultimately how to determine that color, because that's really was the first step in our journey here. Then Tiffany Rodman will be going over some general, the referral process. How do we get occupational therapy to come in and help us? Through our general referral process, as well as through some paid services. Then we'll answer questions.
So when we started this journey, I happened to corner Martha one day when she was in the building, and literally cornered her, "I need you." I had taken the global deterioration scale, and I had started highlighting what fit each of my residents in memory care. What I found out of 14 residents, over 10 of them, 10 or 11, I don't remember, were maroon.
11.
And yet they were ambulatory, they were toileting themselves, they were dressing themselves, so I knew something was wrong somewhere.
Me too.
And as a nurse, I was always trained that if they fall into one area that's higher, that's the level you go with. Which
Or lower, the lowest.
Or the lowest.
Yeah.
No, I went with the highest. That's what we teach in nursing.
Oh, okay.
So that's how I ended up with so many maroon, and I knew in my heart that couldn't be right. They're not that far advanced. So Martha and I scheduled some time. We sat together. In the meantime, Tiffany pulled all of the testing, cognitive testing that had been done previously on the residents in memory care that we still had, sent it over to me, and then we sat and went through each resident one by one, figured out exactly where they fit and why. Martha was able to explain to me more of it being ADL function versus, bits and pieces that I was pulling out. So we sat and we dealt with each of those. We came up with colors. We did some more cognitive testing on some of them. And what we put together was the template. We spent time there going through all of her resources and coming up with common characteristics for each level.
So you have the copies of the maroon, teal, a tan and teal care plan templates. In the meantime, I think Ebenezer had gone to a handheld device for a lot of their nursing assistants. And so as I was working on what would be in a care plan for someone, for example, in a tan level, we found ourselves repeating the same things. Mm-hmm. We were typing over and over, middle stage, step-by-step directions, friendly, warm approach. We were typing the same thing over and over. And we put our heads together and thought, I think there's an easier way than having it all crammed onto their little handheld gadget, right?
Yes.
To this creation of a sheet for each person that has the common characteristics as well as the individualized, there's no one size fits all. And that's, I think, where looking at the global deterioration scale, you were wanting the number to match the color, and really we needed to zoom out a little bit and look at their ADL function, their communication, their mobility. Many pieces were going into how we determined, including the global deterioration scale, determining what color they would be. So we developed just sat down and hashed it out, the care plans, the templates, and then we were adding individualization to those templates.
Yep.
And an important thing that Juanita did was pull in her key staff members. So I think on the next slide, things that we've learned, we are stronger together, all of us. So between Fairview, between occupational therapy and nursing and Ebenezer and the caregivers, and all of us together can create a stronger Dimensions program than one person coming at it at one angle. Mm-hmm. So an important piece was asking the staff, how do you get Mildred in the shower, for Pete's sake? Maybe we should find a way to share that with everyone. And that's on the column of the form that's the individualized tips.
Not only did we pull in my key staff members, I also pulled in activities. What activities does each resident like? What's an easy way to distract them? So gave it to Elise. She filled in a bunch of stuff on activities gave it to the caregivers, sat with them. We figured out activities on them. This is an example of what our book looks like. And then it's by color. So in our TAN, this is a living, breathing document. And I don't know if you can see, there's some purple writing at the bottom. As staff figures out if something does work or doesn't work, they write it on there. And then I will update and make changes monthly on this.
And they sign off monthly that they've acknowledged and read the care plans. So
there's no right or wrong way to do this, but definitely need to get your staff involved and get that that feedback, because they're the front line. They're the ones that are with these residents day in and day out.
Another neat thing she did was make the name plaques on their doors have the color as a background, just so staff people walking in can see the tan or the teal or the maroon, just as a trigger for themselves. You also have the things on your name tag. So I really feel like 9 Mile has come together with this a way that's working. Let's see what's on our next slide. So yes, through this process of ultimately with the binder and staff education, we learned that others were struggling. We weren't alone. 9 Mile wasn't the only site struggling with how to care plan on the memory care units. And implementing the Dimensions program was struggling and inconsistent. And so there was my thinking cap of how can I help. And from the occupational therapy standpoint, I wanted to make sure we had a standardized process for Fairview Senior Services to communicate, because we sometimes will do our testing and we'll verbally discuss it with the DHS, or we'll fill out our communication form. One thing I was doing was creating a whole different cognitive report. So the OTs were going about their piece all different at all the different sites. So in your handout, in your packet, there's a document that I created to help at my sites, and we've decided to implement it across Fairview Senior Services. So it's how we can communicate our OT evaluation results. And it'll be one form that gets emailed to the DHS so that there's an electronic copy. So Juanita, when she gets one, down at the bottom there are individualized care plan tips. It's kind of the tips and tricks. She can cut and paste it right into her living, breathing document for each patient. It gives the scores that are trackable. It tells the color that we've determined. So this is a new form that you're going to be seeing coming through email with the occupational therapist to the DHS. And that was one of the things we learned through our process. And then finally, there was just some confusion on how to use the global deterioration scale and ultimately to find that color, to assign that color. Juanita was a little off in that they were all maroon. That just, I didn't know that's possible, but I've worked with the residents. I was pretty sure that was wrong.
I was pretty sure it was wrong too. So
I know that through your Dimensions training, the global deterioration scale is not something new to you. You understand that it's a way for staging dementia. It seems like there's 101 ways to stage dementia. Your program uses the global deterioration scale. I added a little color coding because I'm visual. But it was developed in 1982 as a way to stage cognitive functioning for a person with degenerative dementia. Stage 1 is you and I on most days. I think maybe I might dip into the 2s every once in a while. Where are my keys? Where am I going? Yeah, it's questionable, but we'll go with stage 1 is normal. Stage 2 and stage 3 you see are the teal colors. And I think what I've seen, at least in the buildings that I work at, is that this population, the teal, are living in your general AL apartments. So they're one to keep an eye on, because you're not going to have a teal care plan for them. But you could certainly utilize what we sent out there for the teal tips and tricks, because they're the ones that you're going to be watching for that are going to probably need to move into your memory care units, right? They're on your radar. So the 2 and 3, they don't think they need help. They're fine, but they're starting to struggle with problem solving and medication management and those higher level skills. And we have a case example of a teal that was struggling and found himself in the tan. And then the tan, we found at 9 Mile anyway, is the majority of the residents that are living on the memory care unit, that middle stage. But it's a big, broad category with the 4 and 5. That middle stage of dementia is you can be in that level a long time. It's a very wide, so that's where the third column to individualize the care plans is very important. You need all the tips and tricks you can have up your sleeve to get those folks to do what you want them to do, and to have them be happy and have their best welfare in mind. This is where things got confusing. I'm going to go ahead to my next slide, because it's this between the 5 and the 6, because the level 5 is split between the 2 colors. So Juanita's like, well, if they look like a 5, I'm just going to call them maroon. So that was that confusion when we were meeting. When you're thinking the number leads directly to the color. In general, it's true. But while we were sitting together and she was talking about all these maroons, I started to ask, well, what about their language, their communication? How about problem solving? What's their mobility? What about their self-cares? How are they doing? So really, I helped zoom out away from the number and the micro, and really zoom out to the whole person to really decide what color they were. Mm-hmm. And that's where I started to develop in my own mind how best to help from occupational therapy's standpoint. Because, in Fairview Home Care, once nursing, physical therapy, or speech therapy, a need or has arisen, they're the ones that can come out and establish the care. I don't know why, but that's just the way it is. So occupational therapy has to be referred from one of our 3, the nursing, the PT, or the speech. And once I'm referred in, what I end up doing, I don't assign the color till way down there, like in the middle to the end of the assessment. I'm coming in and I want to see their cares. I want to see bathing. I want to know what behaviors the staff are struggling with. I want to know what activities they like to do. So I do some activity trialing. I do the cognitive testing. There are different ways to get to that global deterioration scale. The one that I use, and most of the therapists use, is the brief cognitive rating scale, which is a testing instrument that the OTs use to come up with that GDS. We also do a screen, the SLUMS or the short BLESS test, and the Allen Cognitive Level, which, just combining multiple tests to get to a level. And then finally, we assign the color. And from that color, then I start on with staff education. And I create the document, the communication document to Juanita for her to follow up with the rest of the staff. I try to reach as many as I can during my visits as far as staff education on what their needs are and the tips and tricks. This way it's passed over to nursing, and then they can follow up with the rest of their staff. So I email the summary over to the DHS with the color assignment, all those individual tips and tricks, and then you take it and put it into the care plan. It's updated. She talks to activities, gets the activity ideas, and
Care staff.
and talk to the care staff. So then after this whole process, it's added into the binder. And that's that. Yes?
Can you send this to us, or do we have this somewhere? I think for people that are learning about this whole process, that's a really good way to
Sure.
look at it.
I'm going to look over to somebody else to write that down because I'm in the level 2 right now because I'm like, I got a lot going on. But definitely, we'll send the whole PowerPoint. So like I said, I'm a visual learner. So here's my way. This is the new OT way, or it may be just a picture of how the OTs are going to operate on how to determine a color. And it's all of those things we talked about. The mobility, the testing, ADL function, communication, behaviors, all of those things combined together for us to make a clinical determination on whether they're, and I like to think of it early, middle, late, teal, tan, or maroon. And yeah, we'll send that out too as a she's a visual person out here too. So it all sounds great on paper. I think Mary Sue sent me a message. So is this working? Do you have some examples of how did this work through with a patient? So we're going to talk about Rose.
Rose has been in the facility for several years. She is a professional musician, PhD educated, newly diagnosed with Lewy body dementia and Parkinson's. She has, over the last 4 months, increased falls to probably about 5 a week, some weeks. She has just gotten to where she can't walk, she's not able to toilet herself anymore, she's not feeding herself some days. So we had originally put her in as a TAN.
I'd worked with her in the fall, so
Yep.
I had seen her really pretty recently and was shocked to hear this.
Yeah. Because of the changes, we reached out to her primary care, and due to the changes, referred to OT, PT and OT again. PT due to the falls, and then OT because they can't open, so we get PT in and go around it that way. And she's struggling all the way around, significant decline. You can see it if you work with her day in and day out. We were able to see it, but now what do we do with it now that we've seen it? We've care planned her as a TAN. She's no longer a TAN.
Or is she?
Or is she?
Yeah.
You know, so we get the professional in, and we get new cognitive testing. And we've determined now that she is changed to a maroon.
So the staff, when I arrived on the scene, the staff were saying, she needs a hospital bed, we need a Hoyer lift, we need. And I just, want to go through my process, the OT assessment process, because I had known Rose before, strong verbal. I think the quote that I like is, she swears like a
Marine.
sailor, a Marine.
Worse than a sailor.
She doesn't have that filter. So I knew that she was going to be defensive at baseline. But boy, one thing that I've learned about dementia is it's not really a rapid progression. It's a slowly progressing disease, and this seemed rapid and shocking and sudden. So we did check out, is there anything medical going on with her? Medications, any other changes? There really wasn't. So PT opened the case, and I came in and I looked at, she was already care planned as a TAN. Those were some of the suggestions we'd made in the fall. She loves dogs and birds, and she's an opera singer and a violinist. So if you can talk music, you can reach her and she'll put aside her defensiveness. She needs a lot of time to get ready, needs frequent naps, swearing. Yep, you have to be ready for a little swearing. So all the tips and tricks, it looked like, I wonder if these are still gonna work. So I came in and I assessed her ADLs and I completed the testing. Staff was saying she was needing a lift, and I was able to get her to transfer with contact guard assist versus max assist of 2. What I found as I was approaching her was no longer saying, "Hey Rose, how are you doing? We're gonna go to the bathroom now," to stand up, stand, and she'd stand up. So it was a matter of shifting from that tan level approach, or maybe even more of a teal, more conversational because she's so strong in her verbal, to really focusing on, can these maroon techniques work? And they did. We were able to, she didn't need a lift, she didn't need a hospital bed. She needed the staff and all of us to shift our approach to her because we were overwhelming her and angering her even more. With approaches that were not appropriate anymore. And the scores showed it. Staff was very open to shifting their gears and approaching her more in a maroon style, but not, she's still highly verbal, so you want to engage with her about the birds and the music and the opera. And the family was also, a family education is another big component of occupational therapy. This was sort of the bearer of bad news. And the family is working with a neurologist and, getting lots of technical information. And so we're just able to help them to see this shift appears drastic, but really it's not. It was that crossing from the tan into the maroon, stepping over that line, needing different approaches. So then I sent my thing, and we found that most of the tips, the individual care tips for her, were already listed in the common characteristics and general tips for the maroon level, and they were working. So we kept almost all the individualized tips the same, except the maroon and all these falls. We needed to make sure she was kept out in the common area. 9 Mile Creek has this lovely sunny common area, and Rose likes to be out there and sits in the recliner, so we can have a little more eyes-on line of sight supervision. So we added a few little things like that, but this was the perfect example of our process and how it works. I'm going to back up a second, because there was one more, and it happened last week, and I said, "Oh, Juanita, I think we need to add this in." We're going to call him Ed.
Yep.
Let me see. So go ahead.
So Ed moved in last fall. Family had fully intended to put him in memory care. And when I went in and did my nursing assessment, he didn't fit what I felt would be appropriate for him to be in memory care. He would have been combative back there, behaviors would have increased because he was very high functioning. Definitely teal, had some lapses in memory, but he wasn't a flight risk. He wouldn't go out and walk by himself. He liked to walk in the halls, liked to be involved in activities, men's our Romeo meal and so forth every month, outings. So we decided we were going to try him in AL. And he lasted until February, I believe.
He was a new. So you, at that point you got in PT and OT because he was new to the AL. So that triggered, let's get in home care and get his baseline.
Yep.
So we met him at that point.
We met him, yep. We met him while he was in his little teal area, and he was doing very well up until February, and then he started having problems focusing on how to do ADLs. For instance, one of the things he did would take a breakfast plate, and our breakfast is served continental except for one day a week. He would take a plate, a dinner plate, put his cereal and pour his milk on the plate, trying to eat with a fork.
He probably couldn't find a bowl, but couldn't figure to
Right.
ask that.
So little things like that, flushing a brief and his underwear down the toilet because that was his trash can, and flooding his apartment multiple times. Um,
So I'm innocently walking down the hall, and Juanita says, "Martha, I need you." And this happens a lot. So I said, "Did you get a referral? Did you?" She's like, "Yes, I did."
Yep. Start him now. Can you see him right now?
Because he was disrupting the community.
Yes.
They're kind of mean in the dining room. If they see somebody pouring cereal on the plate, it's kind of that high school, middle school cafeteria style. What's the matter with you?
Yep.
So they were being mean to poor Ed, who's just a sweetheart.
He is a sweetheart. So we called Martha in. We did some more cognitive testing. I talked with the family, and they knew the move was eventually going to come. Family had him moved the next weekend.
Before I think just as I was coming in.
Yep, they were so on board with the move because they had seen that too. Couldn't figure out why all of his underwear were gone until we told them, well,
They flushed.
they're being flushed down the toilet. And so with that being said, they moved him into MC within a week. Martha came in, started doing cognitive testing, working with him on his ADLs, on little tips and cues on how to survive. He is thriving back
Solidly
there.
a tan. Solidly a tan.
He is thriving back there. He's going out for all the meals. He knows the staff is going to help him get his plate and his cereal out for him. He's walking up and down the halls just like he always did. He has not flushed one pair of underwear down the toilet. Hallelujah.
He has the help he needs. He has the scaffolding in place to support him so he can be as independent as he needs. Again, the family was just wonderful. I helped her find some activities that she could do with him one-on-one with some larger cards. And yeah, it just happened last week, so I thought this is another really great example. And so we got the OT. He's got his own little care plan now, and all the tips and tricks and things that we learned about him along the way. So that's what's been going on with us.
Yeah, so we've learned a lot through this process.
Somewhere along the way, something got emailed out to Candy at Ebenezer and said, "Look at this. I wonder if this could be something that Ebenezer could use as a whole to try to let the rubber hit the road with the Dimensions program. Really practical. It makes sense to both sides, the OT and the nursing. We look at things differently, and this is where we could come together in a document to guide the staff."
One of the things that was broached with me from one of my staff members is that's just another book to read. So we did some major education. I had Martha come out, and she did a dimensions training with staff. It was wonderful watching a staff member try and teach her how to make a peanut butter sandwich. It was amazing. Everything from gloves on the shoe to
I was having a hard time that day. So part of my training was it was really about communication.
Yep.
And one of the things that you've maybe seen it with some other dementia training where I'm a new employee at a sandwich making factory, and the caregiver is my supervisor and needs to teach me how. So of course they're saying, open up the bread, and so I rip it open because they haven't broken it down step by step. Undo the twist tie to the right, and really just the lesson of step-by-step directions. So that's another thing, and Tiffany's going to talk too about how we can help you. Occupational therapy can come to you for a variety of things, and Tiffany's going to go over that. But the partnership at 9 Mile has included those staff trainings, meeting families.
And then my answer to staff after the training with the dimensions here, if it's on the phone and we're limited with Eldermark on what is in my arsenal that I can put in there, if I put another thing in there under miscellaneous, are they really truly going to read everything that's in there? Each tip. If we put it on the care plan that we currently use, which is a two-sided document, I currently put my vulnerability on the back side. That leaves me this much room to try and put in all these tips and tricks for staff. So that's why we opted for this. We want one page, it's bullet points, it's easy to read, easy for staff to look at. They have to sign off each month when I make changes, and then they're done. They have permission to write on it. I've asked them, make it a living document, write on it. If you see something that works or try something that works, write it down, I will fix it next month.
They've been good about that?
We've just had the binder in place about 3 weeks. So they've been starting it. Could improvement happen? Absolutely. And I think the more they get used to that and the more we encourage them, I think they will embrace it, because they'll come to me with things, you know, I tried this and it worked, or you need to change that because it's not working anymore. And I've asked them, are you writing it on the book? Oh yeah. So they're starting to get there. So,
Should we answer questions about this or hear the Tiffany's piece?
How about we wait and do all the questions at once?
All the questions at the end. Okay, so I'm going to go like this, just as a review. And I'm going to go like this. And switch places. No, go ahead.
Just stare here. Stand by me.
We have similar cuts. So.
Great job.
Thank you.
Great job, Juanita.
Thank you.
Yeah. This has been really cool to watch these two work together and really figure out how to get this all to work together in the community. And it's been fun. Martha and I did do a training already with all of the OTs, so they are familiar with all of these documents as well and will be using them. Anyways, in order to get OT out there, there's a referral process, and there's lots of different scenarios on when we should get Fairview Home Care involved, but one is if there's a new admission. Bring Fairview Home Care out and we can take a look at, the PT can look at their walking. Are they using the appropriate device? Are they not? What kind of tips and tricks can we give? Is their room set up safely? Or do they have every single area rug that they brought from home in there, and we need to have a discussion on why we need to maybe move some of them or sticky tape them down so they're not sliding all over? Speech therapy can also do some cognitive testing. So if there's absolutely no way we can get PT out, if you guys don't think there's a need, bring speech therapy out. They can start with
Communication.
communication and yeah, they look at communication. They can also do some cognitive testing and get OT out involved as well. You know, nursing can come out if there's med changes. And one of the handouts as well, and I know you guys have all seen it before, are these trigger lists. And I believe they're in the training, and I always have some, so if anyone ever needs new copies, I have ones that are actually on cardstock. But it gives all the different triggers that could possibly be used for a referral for home care, whether it be nursing, physical therapy, occupational therapy, speech therapy, and social work. What we missed on here, and it's because it's old and we didn't have our own services, is lymphedema. We do have our own lymphedema therapist now, so just to keep that in mind as well. But this, if you're struggling looking for a reason to I can't just get OT out, I need to have PT or speech or nursing first, this may help you find some reasons to get that referral out there. And certainly please do put OT for cognitive training on there as well, just to give them a heads up. If they move to a different level of care, let's say they go from independent living to assisted living or assisted living to memory care, that's a great time to bring us back in. If there's a changing cognition or changing condition, they've been sick, they went out to the hospital, they've had multiple UTIs, they had pneumonia, the flu, whatever, any kind of change. They're no longer coming down to the dining room on time. Or when they come, they're totally disheveled and look like they haven't showered in a month, or whatever reason. Those are all good things to have us come in and take a look at. A decrease in their slums, noted coughing at meals, behavior changes, if they're being disruptive in the community. I mean, you guys see the dining room. It's worse than the middle school cafeteria. I mean, they're mean to each other. So if you're seeing that a resident's being picked on, it's maybe time to take a look at what's going on. Falls. They're no longer feeding themselves. They have wounds, weight loss, or they've just come back from the hospital or the TCU, and a return, or if they've gone to the ER for a certain reason, it's always a good time to bring them in too.
Oh, yeah.
So the referral process for us, the nurse at the community gets the consent from the family, and then they get a doctor's order for a referral to Fairview Home Care. And what I forgot to put on here is also making sure that if they're not seeing an in-house doctor who's going to do a face-to-face, that we're having that discussion that they need to go in and see their physician for the reason that they're going to be referred to home care. They don't have to have seen the doctor before we see him, but they do need to have that appointment. Once the MD order is obtained, then they're referred to Fairview Home Care. So the face sheet, the Cardex, and the MD order should be scanned to Fairview Home Care using the email distribution set up for each site. Now, I've emailed all those out multiple times, but let me know and I can send them again. Or if you have changes you need made, if there's a DHS change or you want your other nurses on it, I can certainly do that for you. Just let me know. But what we ask is you use your scanner along with this cover sheet. And the cover sheet has the email address right on there, but you also have a distribution list. And what's great about those is then on the distribution list, I'm alerted right away about the referral. Marlene, the nurse manager for senior services, is alerted right away. And Betty, our clinical coordinator who's putting together all the referrals, is notified right away, along with the DHS. If a support nurse is sending in this referral, the DHS is on those, so they get to see it. Oh, yep, they sent it in, great. And then you have when we say, oh, we didn't get that referral, you go, yeah, you did. I have this email right here. So for those of you who didn't hear, this is available on your SharePoint for each specific site. On your site-specific folder in SharePoint. So you have those. I know I do get calls once in a while, where do I get these? And I'm like, well, I know they're in your SharePoint, but I don't know how to get into it. So, and another thing we're going to ask is please be letting the families know before you send us this referral. A lot of times we've been making calls and we go, what? I didn't know they were referred to home care. I didn't know they've had a change. So if you could let the family know ahead of time, that would be really great. So the nurse, once we get the referral, the nurse coordinates with Fairview Home Care for visits. We get consent from the family to come out and do evaluation and treatment. So they're aware that it's coming, but then we still call and get the consent. And then we do our evaluations, and then we give our recommendations to the DHS at the community. Which one do we? All right. So some of the paid services, and I put these on here just so you know that we can still come out and do things for you without the order. We can come out and do baseline cognitive testing if you have people that don't have any other needs and you need it. I'm not 100% sure on the rate, but I believe it's about $70 an hour. We can do environmental assessments of the memory care unit. Martha just did this.
In Roseville in the fall. Oh, yeah. I guess in Roseville during the fall, Lexington, there was a lot of behaviors on the unit and maybe an elopement. I don't know 100% what the scene was, but I came and sat and just after an hour was able to give a listing of some tips and tricks, some ideas, mostly surrounding noise level and kind of setup of the state of the area, possibly putting in a wall so the door that's coming in and out that people are trying to get out of. So I came in and just did an environmental assessment in 1 hour and then sent a report to the DHS.
And the ED.
And the ED.
Yeah.
And at Meadowwoods, they were having I don't know if it just appeared that everyone was having some weight loss. So I came in and observed their dining room and memory care And again, it was about turning off the music and recommendations like having so-and-so, can you split them up split up some residents at certain tables or have their back to the door, just to see if that could help increase intake and hydration. Yep, I think I was holding that away.
Yep, and so that's the mealtime observations. Care planning assistance.
Like we just
Like-
did.
Yep, we just went over.
Was
And
that
then,
like 5 hours? 4 or 5? It was a long time.
3, I think, is what we were charged.
Okay.
okay. And then if there's some intense education at a staff meeting, we don't mind coming in and doing some talks once in a while, but if you're wanting us to come in and do a special presentation at a staff meeting, like communication or,
Behaviors, showering.
yeah, I'm trying to think of the one that Angie did at York Gardens. See, I need memory care. Yeah, it's the one where she put the Vaseline on the goggles and
Oh, sensitivity
sensitivity
training.
training. Thank you. Yeah, things like that we certainly can come into and just talk to me and I can help you get that set up with our OTs. So, and I just realized I forgot to introduce myself. So, I'm Tiffany Rodman. I'm the rehab manager for Fairview Home Care Senior Services Division, and I've been with the program since it started 3 years ago. So it's been really exciting to watch it grow from nothing to, I think we started with a census of about 60 patients, and we are all now up to about 250 on a regular basis, and we had a staff of 0, and I don't even know for sure how many nursing has, but I have 27 therapists that report to me that are out and about in all these communities. We have multiple OTs, we have 3 lymphedema therapists, we have 4 PTAs, we have several PTs, and we have 2 speech therapists and are looking to add a 3rd.
We're
So,
here to help.
We're here, yep, and we love to help, and I'm happy to add more staff if we need to. So, any questions? Yeah, Mary
I
Sue.
have one. I'm wondering if you've worked specifically with people with frontotemporal dementia, and if the cognitive testing works as well with them.
So the question was, have we worked with people specifically with frontotemporal dementia, and does the cognitive testing and the dementia care planning work?
Did I get it right?
Excellent question. Yes is the short answer. Truth be told, and I shouldn't maybe even say this out loud, but I will, I don't care what their diagnosis is. I want to know what their functioning is. What are they struggling with? What are the staff struggling with? And the testing is the one piece. So then using more of a holistic approach to care planning and to the Dimensions program, frontal temporal would be one of those causes of dementia. So absolutely. Stroke, Alzheimer's, alcohol-induced, all
Lewy
different
body.
causes of dementia.
Lewy body.
Lewy body. I want to know how their function is affected.
Parkinson's.
Parkinson's is another big one.
Yep. Any other questions?
I don't have a question, but I do have a comment, and I'm Mary Meacham, I'm one of the regional nurses. So I think I observed through questions that I was receiving from the directors of health service, the confusion that Juanita experienced with determining the color, because one of our assessments for determining the level of care is that you're looking at all these different categories, and there's level 1, 2, 3, and 4. And if somebody is considered a 4 in one category, and all the rest are 2, we count them as a 4. So
Yeah.
I understand, I think that was part of the confusion that possibly a lot of our communities were having. So thank you for helping to
Yeah.
make
So-
people realize what a subjective
Yeah.
assessment is.
So what Mary was saying was a lot of the nurses, when you are categorizing your patients as into their care levels, they're 1 through 4. And when you look at dimensions, it was 3 categories. And when you guys, just, this is how I think of it. If someone needs a 2-person transfer, if they only need it once a day and not all the time, they're an all the time on the care plan, and that puts them into the category 4 or whatever category it is. So that's kind of how nurses are used to looking at things. And so when taking a look at this, I think a lot of people were saying, well, they do this sometimes, so that makes them a maroon. Or they do this sometimes, even though most other things may fall into tan. And that's where it's been helpful. Did I get that right?
That's absolutely.
Okay.
And I think one of the indicators in the maroon level talks about hallucinations. And we know that our teal level Parkinson's people have hallucinations. So does that make them maroon? So it was that learning curve of let's zoom out, and look at them holistically.
Anyone else?
Yeah. Question. When does the color get determined? Is that?
The question is, when does the color get determined? So let's say you have a new move-in. How we've been doing it, Juanita's making her best guess because you have to care plan for the day they walk in. So she's making her best guess, and it's getting better, by the way.
Thank you.
And then the referral comes as quickly as possible, and then we'll tweak it. Sometimes it's off, sometimes it's right on, and then we individualize it. And then also, as you're going along, I'm envisioning throughout the year when you have a nursing assessment, you're going to want to add into your thinking, is their color right? If you're not sure, get another referral. Let's have OT take a look at it again. If you have a hunch, I don't know how often your assessments are, but adding that into a checklist of, is their color right on memory care?
I think that what you're saying at the very beginning is when we, there's a gap of time between the time they're admission and the time that you kind of do your full scale assessment and get really like a true color, full care planning and things like that, that it is your best guess.
Yes.
And that's okay.
Yep.
And I think that's what some of the nurses are really struggling with is, what if it's not perfect? And it doesn't have to be perfect because we're there every day. And so I think giving people permission to say, this is where I think they're at, this is where we're going to go with it. And as time goes on, it's okay to change that. But giving people permission that it's okay to look at your nursing assessment and give a best guess. The person who is going to fully scale assess that person is the OT or speech, but OT, and really come up with a comprehensive assessment to allow us to better care plan.
Yep. So basically what Teresa was saying is that it's okay when you make that first as the nurse and you're doing your assessments on a move-in or your annual assessment, it's okay to say this is my best guess and then work with your OTs to tweak it later. And people are going to change. That's the nature of who we serve and who we work with. None of them are going to stay the same forever. Even if they're independent living, they will eventually change. So, it's important to keep looking and keep reassessing and make your guess and then bring in the help that's needed. We're here to help you.
And I think, like I said, giving people permission, there's just
Yep.
a lot of anxiety around
Yep.
this color or this number, and it doesn't have to be that way.
Yeah. So
The best guess is okay.
Teresa's saying that you have permission to make your best guess, and it's okay if it's not exactly right away. But, don't be super anxious and worried that it's not perfect right away. That's okay. I mean, this is a great example of collaboration, Juanita, and there was no tension that I know of, at least when Martha said, well, Juanita, I don't know that all these people are maroon. You were wrong.
I'm friendly about it.
It was okay. And you guys talked through it, and I think you both learned a ton.
Yep.
Yeah.
That's good.
Okay. Anything else?
That's exciting. Yeah.
All right. Thank you, everyone.
Thank you.
You're welcome.